Good morning. My name is Chris Denson. I'm the Director of Policy and Research at the Georgia Public Policy Foundation. I'd like to thank Chair Donatucci, committee members, and Leo for his assistance in getting us all here today. So thank you for your time. We're a nonprofit think tank. We focus on economic policy. We were established in 1991. We also have a 501c4 affiliate that advocates for certain issues that we work on. And personally, before I joined the foundation about 5.5 years ago, I spent about 5 years at a rural hospital trade association, about a year or so at Memorial Health down in Savannah doing rural health outreach, along with some time on the staff of a U.S. Senator in D.C. and working for an HHS secretary focused on rural health issues. So spent a lot of time thinking about this issue and just how do we preserve access to rural health care, especially here in Georgia. I believe you've seen this data previously in this study committee, but it's worth reinforcing while we're here today. You'll see that the overwhelming majority of our state, even in metro Atlanta, are considered health provider shortage areas. Over 2.75 million Georgia residents live in a HPSA. You can see where the Navy is here in the state. And then there's some data as well that shows that Georgia is projected to be short over 8,000 doctors by 2030. I believe you've heard some of those trends and reasons why, but it's an aging physician population. And something that will come up here later today is, as a country, we actually produce more medical school graduates than we have federally funded residency slots. So I believe you heard last week that we're capped based on 1990 population numbers. So these are some issues that are creating a bottleneck in terms of getting more physicians out into not only rural Georgia, but really across the country. So as you heard Chairman Parrish mention last week, the state legislature inserted additional funding for residency slots both into the amended 25 budget and the fiscal 26 budget. And it was around a year or so ago that I was thinking about, in terms of what we do as a state and the funding that we provide for residency slots. And I was having this conversation with a former state legislator who is also a rural physician. And he pointed out to me, he said, it takes roughly 7 years of training to produce a physician. So even if we fully funded all these slots, you still have a lag in terms of getting these physicians out into these communities. And so the premise behind what I'm talking about today is essentially what are other states doing to supplement the traditional physician in underserved areas. And so you'll see up here today, I have 4 things outlined. The first is this concept of expediting the path to practice for internationally licensed physicians. The second is the creation of assistant physician programs. And these last 2, I'm not going to spend time talking about today. For those of you who are veterans of the legislature, you'll know that these scope of practice issues are sometimes political third rails. But the first 2 really utilize medical school graduates. So I'm going to focus on those 2 today, but if anyone's interested in learning more about bullet points 3 and 4, I'm happy to have that conversation. Before I move on, I will note that currently 28 states and the District of Columbia allow for nurse practitioners to independently see patients. And then 5 states in recent years have started allowing pharmacists increased scope of practice to see patients. So as well, and I'll move on from there, but if you have any questions, glad to have that conversation offline. Okay, so this first one, internationally licensed physicians, because it's healthcare, we have to have an acronym, ILPs. They're also referred to as foreign medical graduates, internationally trained physicians, but this is a concept that has really grown like kudzu in recent years. I remember I was at a conference in early 2024, and at that time, Tennessee was getting ready to launch the first in the country version of this program. Since then, I believe we have, I know I have it on a future slide here, but 18 states have since implemented a version of this law on their books in the last couple of years. And so what the program is intended to recognize is that we have actually immigrants, legal immigrants living in the country that have been practicing physicians in other countries. The very common story you'll hear is they're here in the US working as Uber drivers. And so, there's this idea in policy circles that how do we utilize their medical experience and get them from working in the service industry and get them back into the US healthcare pipeline. The second point here I'll notice is, if you're talking about let's just say it's an orthopedic surgeon, an oncologist, and they're practicing in the United Kingdom and they want to practice at Emory, for example, they still have to go through the same residency program in Georgia that a medical school graduate goes through. And so that's part of the reason why Tennessee and these other states have said, hey, this is, somewhat redundant, especially when you consider the fact that we have this bottleneck of more medical school graduates compared to residents. And so why do we have trained and practicing physicians competing for the same residency slots as fresh medical school graduates? So when thinking through the utilization of these ILPs, there's a couple things to consider. One thing obviously is when an immigrant goes through the migration process, it takes several years to attain legal status. And so a lot of these states are tackling how many years do we want to essentially provide a grace period in terms of looking back if they've been out of practice. If a foreign physician has been out of practice for 10 years, maybe that's not quite the same as a foreign physician that's been out of practice for 1 year. Maybe they need to go through the traditional residency program. So you're seeing a lot of variance in terms of the way states are tackling this window of what's called a look-back period. Another thing as well is that a lot of states are requiring these international physicians to already have a job offer from a hospital or a health system before they allow them to enter this program. There is a version of this bill that came up in the Georgia Senate in 24 and 25, and it was essentially 2 tiers. So the first was the provisional license. And so for 2 years, you would be, if you're a foreign physician, you'd be employed at a hospital or a health system. Some versions of the bill expanded the definition where you could be a federally qualified health center or at a university, like in a teaching position, to ease that transition into the intricacies of the American healthcare system. And then after the successful completion, everything goes well, you have good letters of recommendation, you would then enter a 2-year period in a provisional license, under a provisional license, and you would then have the ability to practice a little bit more independently, but you're still working in a medical underserved area or a health provider shortage area. And so then after that, you'd have the ability to apply for a full license through the Georgia Composite Medical Board. There are a couple of, in diving into this issue over the last couple of years, one kind of common misconception is that, it seems like everyone seems to have this anecdote of, they know somebody that applied for med school in the US, they didn't get in, they went to the Caribbean, and then they're just going to come back here and essentially bypass the residency program and then start practicing as a physician. I mentioned some of those safeguards in place, such as the look-back period. A lot of states are saying, okay, you have to practice for X number of years before you can even be considered. So there are a lot of rules and regulations put in place to safeguard against that. Another kind of common concern with this program, and I think this is pretty consistent across like the healthcare system when you talk to people that are recruiting physicians, is that we have an accrediting body for medical schools around the world. That is the Education Commission on Foreign Medical Graduates. So they're essentially evaluating, is this a quality accredited medical school? We don't really have the same level of breadth when it comes to evaluating residency programs. So you're seeing a lot of states kind of put in some qualifiers in there in terms of allowing for leeway within their state medical boards to evaluate the quality of the candidate because, for example, we have the ACGME, which is the Accreditation Council for Graduate Medical Education. That is how residency programs are accredited here in the US. They have an international arm. But for example, they only have accredited 22 sponsoring institutions, so 22 residency programs in 12 total countries. So from that standpoint, you're seeing a lot of states almost having like a set list of countries they're accepting international physicians from. And they'll typically Western European countries are more popular in terms of set space, but that's kind of just to keep in mind the quality of the candidate you're receiving. The last criticism you often hear around these programs is that there's no path to board certification for a foreign physician when they come here. A lot of hospitals and health systems will require physicians to be board eligible at the minimum when they come on. And so in the last couple of weeks, interestingly enough, for the purposes of this committee, the American Board of Internal Medicine has announced a pilot program to help facilitate foreign internists to become board certified if they meet a certain set of criteria. So they're recognizing the growth of programs like this around the country, and they want to help facilitate ensuring the quality of candidates through the Physician Society as well. Here you'll see a couple of our neighboring states that have adopted programs like this. That first bullet point, that was 18 states. What that essentially is, if you go through the kind of provisional license, the limited license portion of programs like this, there is a pathway to a full license to practice independently, typically in a medical underserved area, without undergoing the traditional residency. And then you'll see we have, 3 neighboring states here that have already adopted this. The second bullet point, you'll see these are the states that have legislation like this under consideration. As I mentioned, Georgia has considered this bill in 24 and 25. And then the last point here, there are 3 states that have implemented a program like this, but they don't actually have the pathway to a full licensure at the end for international physicians. So you can come in, you can practice under a limited and provisional license, but then there's no transition to actually allowing them to practice independently. The second program, as I mentioned, are assistant physicians, associate physicians, and I think there are about a dozen different names for this program that are popping up around the country right now. But this came about, it first passed in Missouri in 2014. There was a state representative who was also a rural physician who recognized that he was encountering medical school graduates who did not match his residents. And he documented the kind of financial and emotional strain from that. And he thought, we need to put them to work somehow into our healthcare provider pipeline. And so what you're looking at here is, okay, like you have not matched as a resident. And typically what they'll allow you to do is to work as essentially almost like a PA or an NP under physician supervision for a year. Some states allow up to 2 years, some allow to 3. And then there's this limited scope of practice that they allow for these assistant physicians to undertake. The other third kind of common criteria you see is this requirement to practice in rural and underserved areas. So they're essentially taking them and putting them out into where they're most needed in that year or two while they try to go through the residency application process again. For example, I've written down a few things about Missouri because it was first in the country. But so an assistant physician enters into this collaborative practice agreement with the supervising physician. The supervising physician is required to review 10% of the AP's charts every 14 days, as well as 20% of the charts where controlled substances are prescribed. Additionally, the supervising physician and the assistant physician must complete 1 month working together continuously prior to practicing at different locations, and they must complete over 120 hours of on-site practice prior to the assistant physician being allowed to prescribe controlled substances. So Missouri, which I said was a physician-crafted law, had put several safeguards in place, but from a high level, there's a lot of variance in terms of what you're seeing across the country when different states develop these programs. That I'll go to my next slide. So for example, you're seeing some of these APs being able to practice for 1 to 3 years. Some of them, you can renew your license once, twice, not at all in some instances. And so here you'll see our neighboring states as well that have adopted a version of this program. Again, we have 3 neighboring states. The only difference here this time is that Alabama takes the place of North Carolina, Tennessee and Florida, the 2 common denominators here. We have not had a version of this bill introduced yet in Georgia, but in the interest of full disclosure, I have spoken with several of your House colleagues that have expressed an interest in exploring this concept and introducing a version of this bill in 2026. The other thing I'll note is that this idea of assistant physicians, you're essentially taking physician assistant and you're flipping the words around. It can be pretty confusing. So just some examples we're seeing across the country in terms of other names: bridge year graduate physician, graduate assistant physician, special permit, supervised medical graduate. So it's just another example in which states are really kind of inserting their own flavor, and there's no one size fits all that we've seen across the country in developing these bridge year programs for unmatched residents. And then lastly, and this might flow into any kind of questions you might have about assistant physicians in general, but what you're seeing, one other consistent theme you're seeing across the country is that as states are looking into implementing these programs, they are viewing them as like a bridge year. What you're then seeing is states that have these programs on the books for several years, like Missouri, are then saying, okay, we have medical school graduates that have found they enjoy being an assistant physician. They don't really want to undertake the traditional residency. So how do we either have a path to full licensure after like 5 years of doing this? That was one bill that was introduced and did not pass in Missouri. Or how do we allow an option for them to continually renew on an ongoing period? So they're under review with the Med Board, but they can stay in this collaborative partnership agreement similar to a PA or a nurse practitioner. Lastly on that one, as I mentioned, there are multiple variances in the way states have implemented this program. I'd be happy to provide like a written landscape analysis that we've done to Leo to share with the committee. You can see, as I said earlier, the way the states have really inserted their own kind of specifications in there. But with that, I'm happy to take any questions that the committee may have. And I know those are 2 pretty dense concepts I had to cover in a short period of time, but I appreciate your time today.